So, to improve the pre-test probability of obstructive sleep apnea, there are various questionnaires available. The most commonest question is use a Berlin questionnaire, which is usually done in the primary care setting, and also is a stop bank questionnaire, which is used by the anesthetics in the preoperative assessment. So, this is the sample questionnaire, which is a stop bank questionnaire, which gives various information about the patient, including snoring, history of tiredness, observed apneas, blood pressure, body mass index, age, neck circumference, and the gender. Based on this, you score them. So, answer of yes scores 1 and answer of no scores nothing. So, if you have 3+, then there is a high risk the patient could have obstructive sleep apnea. Next, we come to polysomnography. Nocturnal polysomnography is a lab-based study, that is a level 1 study. It is a gold standard for obstructive sleep apnea or sleep breathing disorders. The polysomnogram measures EEG, which is electroencephalogram, EOG, electrooculogram for eye movements to detect REM sleep, EMG mainly for submentalis muscle, which is electromyogram, and you also have EMG for limb movements, which is connected to the lower limbs to look for periodic limb movements of sleep. You also look for thoracic and abdominal movements, and you also look for heart rhythm, rate, oxygen saturation, respiratory rate. You also measure the airflow through the nose by nasal pressure and temperature monitoring. You have a microphone to measure snoring. You also measure the body position, and you have a video monitor for any behavioral problems seen during the night. You can include, if needed, a transcutaneous carbon dioxide monitoring, or it could have a tidal carbon dioxide monitoring done during this procedure or the investigation. It monitors and quantifies all the respiratory events and the physiological consequences, which is hypoxemia, arousals, awakenings, obstructive apnea or hypopnea. How reliable is the polysomnogram? There is significant variability from night to night of the disease severity itself. So, this variability is high in patients who have mild to moderate obstructive sleep apnea, and you can do the test on a night and find that they have no obstructive sleep apnea. If you do the test the very next night, they might have AHI, which is high enough to be called obstructive sleep apnea. There is also difference in reliability of the lab equipment. There is also reliability of how experienced is the person who is doing the scoring, and also the scoring protocols which have been used. There is different definitions for hypopnea, like hypopnea recommended by AASM and hypopnea acceptable again by AASM. So, this is important to know what protocol the lab uses to define hypopnea before you can interpret the report. As I mentioned already, because there is a significant night-to-night variability in the severity of the obstructive sleep apnea, you can find that about 20 to 50% of patients who had an initial polysomnogram negative for obstructive sleep apnea can be found to have obstructive sleep apnea on the repeat polysomnogram. The other interesting point is that we have a very poor correlation between AHI, which is the apnea hypopnea index, along with daytime sleepiness. We measure the severity of the obstructive sleep apnea based on the AHI because it's easily measurable. It does not mean that it has to correlate with all and every symptoms caused by obstructive sleep apnea, and we find that there is a poor correlation between AHI and the excessive daytime sleepiness.